Every rural care provider in the United States can attest that finding, hiring, and retaining clinicians across just about any specialty is getting harder and harder. In South Central Washington State, Kittitas Valley Healthcare, KVH, the only provider offering comprehensive OB/GYN services for many miles around, was suddenly faced with a huge problem. Within the space of about a year, its 3 full-time OB/GYN specialists all decided to leave. Welcome to Advancing Health, a podcast from the American Hospital Association. I'm Tom Hetterly with AHA Communications. Prior to 2022, KVH was delivering between 300 and 350 babies each year. Its 6-bed labor and delivery unit was the most in-demand service the hospital offered. In this podcast, we learn from the hospital's CEO how KVH kept its balance and its promise to area residents to preserve critical obstetric services in the wake of the departure of several highly experienced clinicians.
Good day. I'm John Supplett, Senior Director of AHA Rural Health Services, and joining me is Julie Petersen, CEO, Kittitas Valley Healthcare and Public Hospital District. Good afternoon, Julie.
Hello.
For our listeners, Kittitas County Public Hospital District Number 1, also known as Kittitas Valley Healthcare, provides care to Kittitas County and surrounding areas in central Washington state. KVH includes a 25-bed critical access hospital and provides care through clinics and specialty services in Upper and Lower Kittitas County. Julie, we're here to discuss how KVH has responded to a crisis to ensure continued access to obstetrical care in Kittitas County, Washington. How essential is obstetrics to your community?
We know from our latest community health needs assessment that admissions for women of childbearing age is our number one admission to our hospital. So this would include deliveries as well as complications from deliveries and prepartum and postpartum issues. So it's not just an essential, it's a core service for our community.
And I think I want to pull a thread on that because it's remarkable when I looked at your community health assessment and improvement plan to see these conditions as being the highest source of admissions to the hospital for women of all childbearing ages, including teenagers.
Correct. And we staff a dedicated labor and delivery unit, a 6-bed labor and delivery unit. We are a 25-bed critical access hospital. So our general med-surg CCU population includes a number of different DRGs and conditions. But again, the number one major diagnostic classification that we have is those moms, prepartum, postpartum, and the deliveries themselves. And we deliver about 300 to 350 babies a year in Kittitas County. We have about 80% of the market of deliveries. And we're very, very careful in how we screen our moms. We know our limitations with our labor and delivery program. But again, that's 300 to 350 babies a year that rely on us to deliver them in Kittitas County. We are the only hospital in the county.
And that's a remarkable number. And I think we need to really get a sense of where you are relative to the other providers in your area with respect to location. You're in South Central Washington. To the south of you, the nearest city is Yakima.
That's correct. So any direction you want to go to deliver outside of Kittitas County, you're going to have to travel over a mountain range. You travel to Wenatchee, which is a mountain pass. That's about 40 miles. You can travel to Yakima, 35, 40 miles over a mountain range, or into the Seattle metropolitan area over the Cascades.
And so recently you've experienced significant disruption in your OB/GYN services. Tell us what happened.
Prior to 2022, we have worked with a pool of community providers, including those sole practitioners who retired in 2022. We also had an FQHC in our community that participated in our call and delivery program. And due to changes in the residency program and then just a tight OB market, that program has slimmed down in our community. But we have employed 3 OB/GYNs in our community, has been kind of the core of our model. But in 2022, all 3 of those providers gave us notice that they would be leaving. 2 of them continue to live in our community, but they travel to metropolitan areas to participate in laborist programs in the large hospitals.
Well, and again, I have to pull a thread on this because your model through 2022 was an employed service through your own OBGYNs, which is remarkable to think that you were able to recruit them into the first place and that they were committed to the community for so long a period of time.
Right. And that level of commitment, that market of being able to employ an OBGYN who is responsible for their patients 24/7, who disrupts their clinic life to go to the hospital to deliver a baby on the middle of a Wednesday afternoon, that market is harder and harder to draw to, and that is absolutely what we were trying to maintain in KVH. Again, with the participation of some great partners in the FQHC and some private practitioners. But within the span of about 14 months, that entire model just came apart on us.
So you get punched in the gut as you see this attrition in your employed model of care. How did you respond to this crisis?
Well, the governing board, we are an elected board of 5 commissioners in Kittitas Valley. And they came out of the gate assuring the community and assuring our staff that we were going to remain in the OB business. So my charge was to make it happen. We'd already been recruiting to replace the traditional OBGYN community-based providers that we'd had in the past, and we were not having very much success. We did come across a family practice OB who is surgically trained, who's a key component of our program going forward. But after about 12 to 14 months of looking to backfill our OBGYNs, and we had no choice but to look outside for an outsourced service. And we found a partner in OB Hospitalist Group, or OBHG. So again, I think the first thing we did was make the commitment from the governing board on down that we were going to continue to deliver babies in Kittitas County. And that's key because one place where we're particularly strong is in our nursing program. We have an amazing group of labor and delivery specialty trained nurses who have stuck with us through this entire sort of meltdown in OB. And the last thing we wanted to do was make ourselves vulnerable to losing those nurses.
Well, and I'm going to share a couple of observations. First and foremost, that this is a public district hospital and that the board is committed to delivering babies to this community.
That's absolutely correct.
And that's at the core
Right.
of your mission.
Right. That was never a question. And I think the way we see this is, again, our folks have been rigorous in determining who should deliver at KVH. We don't do high-risk deliveries. And when you take 300 to 350 moms who can deliver in a safe hospital environment and put them on the road over mountain passes or 35, 40-mile stretches, you take low-risk, comfortable births and you turn them into high-risk births. That was not acceptable to my board.
And then the other observation is as we see hospitals drop obstetric services from their service components, I, again, reflect on the fact that as a public district hospital, your commitment to the community is at the core of what it is that you do. And in this particular, you're willing to take on this loss leader in order to make sure that there's access to safe care to the women that live there.
And we see this service line also, at the core of this service line is labor and delivery and obstetrics. And that certainly is the biggest challenge in terms of continuing the service line. But it is bigger than that. We are a county of about 45,000 people, and we're a little bit unique in that we are growing as a sort of a long-distance neighbor to the Seattle metropolitan area. We are growing, and we're holding our own in terms of age. So we're not aging the way some rural communities are. So long-term, we need not only to be able to deliver our own babies, but we need to be able to take care of women generally in our community. The reproductive health needs of women, gynecological needs of women in our community are core to this as well. And if you can't attract OBGYNs, if you can't attract the nurses who care for women in the clinics and the hospital, you're going to lose your ability to take care of women generally and reproductive health specifically.
Julie, let's talk about the selection of OB Hospital Group as your agency to service this laborious model. There had to be some research that went into that. There had to be some board buy-in and acceptance of this. Tell us a little bit about that process and how it went.
During the pandemic and initiating our research, one of the things that we learned is in a very short period of time, many, many hospitals had transitioned to a laborious type model. And while it's largely an urban-suburban phenomenon, we saw some of it moving into the rural communities as well. So we looked for somebody who had experience in rural communities. And rural is different than urban. They needed to be able to, or willing, they needed to attract candidates who would work in a clinic setting, who would do GYN, general GYN surgery, and to that time as a laborist as well. So we needed to partner with someone who would be flexible, who would include our own dedicated staff, our family practice OB that I mentioned, our certified nurse midwife. We had folks who we knew were really dedicated to our community, and we needed a partner who would build around them. So we worked with OBHG. They basically sat down with us and said, let's build some schedules, let's see how we can make this work. And we settled on a 3-week-a-month rotation. When you were on call to deliver babies, that's all you do. So again, delivering maybe a baby a day, that's not overly burdensome. It is a 24-hour commitment, but for 7 days, that's what you do. The next week you get off. You return to clinic work and just clinic work for the following 2 weeks. And that seems to have been an attractive model, not just for our own delivering physicians, but for OBHG as well. And they're having some success in recruiting to that position.
Well, which is excellent news, and I'm sure a relief to you. So this is how you're going to put this model into practice. How has the community received the message, or do they even understand the message that you're changing the model? Is it relevant to them?
You know, you lead with the fact that except in a rural community, people don't expect the OB they see in their clinic to deliver their baby in very many facilities anymore. So this is not new to people. It's new to Kittitas and to our population, but they were very much aware of it. And if they delivered somewhere else, that's probably the model that they had seen. The thing we had to say over and over again is that we are committed to this. It's not going to be easy. We're not going to be able to do it overnight, but we have never been on divert for deliveries. So whatever it took to pull that together and keep that service intact, our board has been willing to make that commitment and do that. And frankly, I think the community has come to believe us. They've seen how we've struggled, but they know we're in it.
Nevertheless, Julie, it's a radical change in the way in which you've delivered OB in the past. I'm curious to know, given the importance of the nursing component, how has your nursing service responded to the change?
Labor and delivery nurses are the number one reason that we're seeing rural communities go out of the OB business. So while we have struggled with the OB/GYN component, with first assist, of course you have to have anesthesia available. You have to have someone there to take care of the baby as well. You have to have pediatricians or acute newborn providers in a cesarean section to take care of the baby. So it takes a team, but our nurses are the bedrock of that. And we talk about labor and delivery. 11 hours of labor and delivery is all about the nurse. The doc walks in and is there for a short period of time. Our nurses are dedicated. They have a lot of longevity, and they are just used to doing whatever it takes to get the job done, and that's what they've done for the last 15 months.
So all these things considered, given the changes that you're planning, 2 questions. The first is, what's the timeline for implementation? You really started this process back in 2022, 2023. You've moved forward for the research. You made the decision to go to be with OB Hospitalist Group in October of 2023. What's the timeline now for looking forward in terms of making this permanent?
We believe we will be fully staffed between our own providers and OBHG in July of this year. So it has been a long haul. We've been on the pediatric side of it. We've been building our acute newborns so that's a very reliable group now, and anesthesia as well. So we feel like once we have weathered the storm of a lot of locums and short-term locums, and we get our OBHG hospitalists on board, our own folks on board, we're going to be ready to go. So July, August of this year. And again, a component of this, and one of the ways that we make this affordable, and labor and delivery has always been a loss leader, but one of the ways we make this affordable is through this OB/GYN model, is we do have built-in GYN surgical time. So we're able now, or we will be able to take care of more of the general gynecological needs of the women in our community than we've ever been able to take care of before.
Well, and I think that that's the question, and that'll be the last question I ask, and it's the one that everybody wants to hear is, how are you going to pay for this? How are you going to meet the expenses to make sure that this service remains viable moving forward?
So every schedule we've put together also includes that GYN surgery day. So our OBGYNs will be doing more surgery than the ones that have been working 24 hours a day to deliver babies were willing to do. So GYN services will continue to increase. This, frankly, is a service that we have always looked to our 340B savings to help support. And like everyone else who delivers babies, we lose money on it. So we made a direct connection to those 340B savings. So we keep a close eye on that as well. It is not going to be easy. Financially, we will struggle because of this, but again, we're committed.
Well, and you raised some very important points, is that none of these programs exist without the other, and 340B is essential to rural community hospitals across the country. It is the margin for many critical access hospitals, and what you're suggesting, it is going to be pretty much the margin for you to be able to continue this OB service. I think I really, on behalf of all of our listeners, want to thank you and your board for the commitment to making sure that OB is available to the residents of your community, that they're not put at risk for unsafe deliveries, a healthy situation becoming unsafe because they have to cross a mountain pass. I think it's a huge commitment on behalf of your community and your leadership in making this happen, to really implementing this practice and making it come so quickly, given the crisis that you were confronted with just a few months ago.
Well, thank you. It's a privilege.
I want to thank my guest, Julie Petersen, CEO of Kittitas Valley Health in Ellensburg, Washington, for sharing her important story on providing essential health services and reimagining OB to ensure continued care for the residents of Kittitas County. Your commitment is inspiring, and we'll be watching closely as you grow and evolve under this new model of care. I wish you every success in your effort and hope to learn more about how we can learn from your experience. I'm John Supplett, Senior Director of Rural Health Services. Thank you for listening. This has been an Advancing Health podcast from the American Hospital Association.
Thanks for listening to Advancing Health. Please subscribe and rate us 5 stars on Apple Podcasts, Spotify, or wherever you get your podcasts.